That's obviously been a fantastic opening speaker, and we're going to move on next to our next speaker, who is Ria Crichton. Ria is a clinical nurse pain specialist who has worked with patients experiencing acute pain after surgery or due to illness or injury, as well as patients who are with persistent pain for almost over 10 years of work. She's been doing that. We're also delighted to say that Ria is a member of our medical advisory panel. So without further ado, I am going to welcome Ria today to talk to us about pain management.
Hi, my name's Ria. I'm a clinical nurse specialist working within an NHS pain team. I'm also a member of the Pelvic Radiation Disease Association UK Medical Advisory Panel, and I'm a person with lived experience, not only just of pain, but also of pelvic radiation disease. So this is a subject that's very, very close to my heart, and I'm very grateful to be given the opportunity to be talking to you today. So let's begin. So there are many pains associated with pelvic radiation disease. Often these will start during treatment within a couple of weeks for radiation. These are the acute effects, so it can be bowels, bladder, pelvis, especially skin changes as well. These can then become longer term, so if those pains that start during treatment don't settle within a few months, then these would be classed as long term. And then there's also the late effects. So these are symptoms, pains that can occur several months or even years, decades after treatment is finished. So many of these pains will be classed as musculoskeletal, so these affecting the bones, the muscles, could be due to fractures, menopause, deconditioning due to reduced activity, inflammation, often described as gnawing, aching, throbbing, pulsing. There's the neuropathic pain that people experience. So this is due to changes to the sensory and motor nerves, can be described as burning, stinging, electric shocks, tingling, weakness in the muscles, some altered sensations, so either areas of numbness or areas of increased sensitivity, and can lead to muscle tremors and twitches as well. And then there's the visceral pain, which is to do with organs, so generally the bowel and bladder, often described as cramping, griping, spasms, sharp stabbing, and often associated with things like constipation, diarrhea, urgency, frequency with urination or passing stool. Well, what is pain? So pain is more than just an issue with the tissues. It's complex, it's multifaceted. Pain is a perception, and as such is altered by all of these things that you can see on the screen. So no two individuals will ever experience pain in the same way. So even if they've got exactly the same condition, it will be very, very different because all of these areas will be different for them. So I'm not going to look at all of these factors, but I will focus on a few of them. So the things that I feel really, really stand out are the social factors. So what area we're brought up in, how our family deal with pain, all of those things can shape how we experience pain as an adult. There's a lot of research going on at the moment about children who are brought up in households with adults with pain and how they experience pain as well. Psychological factors, so we know that history of trauma, depression, anxiety are risk factors for developing persistent pain, and they also increase the severity of pain as well, so they turn the volume up on our pain experience. And beliefs, so beliefs are such an important part. If we have very strong beliefs about what our pain is caused by, what our pain means, if we can have control over that pain or not, it will change and shape how we experience that pain. So for instance, if somebody has a very strong belief that they have control over their pain and there are things that they can do to manage it, that will put them in a much better position to be able to manage it than if they have beliefs that the pain is completely out of their control, or that the pain is a punishment or an infliction, which is meant to teach them a lesson. So again, that brings that in those cultural issues and also some religious beliefs as well. So it's really important that we take all of these into account when we're trying to manage pain. So the consequences of pain. So we've looked at what pain is and the things that can increase our risks for them, but what about the consequences of having pain? So pain impacts all aspects of our lives, each of these areas affecting the other areas in turn as well. So physical consequences of pain, as you can see here, deconditioning, so we become less active, we move less, so everything gets a bit weaker and stiffer and tighter. We become more fatigued, often because our sleep is disturbed, but also the treatment that we have for cancer can cause us to feel very fatigued anyway. Sleep is such a big issue. Not only the pain disturbs the sleep, but some of the symptoms as well. So bowel and bladder urgency and frequency can disturb sleep. We do all of our growth, our repairing, our tissue healing during our sleep. So if we're not having that restorative sleep, then that can have a huge impact on our physical well-being, as well as our mental well-being as well, and can worsen the psychological consequences of pain too. Stress is another area that's really important to try and manage and control. We can't always, but if we can have more coping skills to deal with it when it happens, then we can manage it better. So stress has a huge impact on our pain experience. So if we have very unmanageable stress levels, then the volume will be turned up on our pain as well. And vice versa, if we can get our stress under control, we can then in turn reduce that volume on the pain as well. So the psychological consequences of pain, so depression, anxiety, trauma, we mentioned them, talked about them with regards to the risk factors, but actually they are a consequence as well. So you can see this kind of circle that's starting to develop. Grief and guilt are two things that aren't talked about as much. So there's a lot of grief that's experienced by people who go through a cancer diagnosis and treatment, as well as living with a long-term condition. So that grief around losses, so the loss of who we were before, who we wanted to be in the future, maybe the loss of our role, so financial, our occupation, our income, our role as a husband, a wife, a daughter, a friend, a work colleague. All of those areas are really impacted by pain. And again, you can see that all of these areas start to interlink with each other. All of those losses from the social side of things and how it affects our relationships with our loved ones then has an impact on our psychology as well. So we often feel a lot of guilt regarding not being able to do the things that we used to do, not being able to take care of our loved ones in the same way, or not being able to have as much energy to do all the things that we want to do anymore. And that then again impacts how we feel, can cause more depression and anxiety, which again will impact our sleep and will impact our stress levels. So all of these things just turn into this very vicious circle of pain and stress. But it's really important that we try and manage this and try and take all of this into account when we're managing pain as well. So how can we manage pain? So if we're looking at pain from a physical, psychological and social point of view, then we need to look at it from the management aspects. Now, all of these things need to be managed as one. You can't do any of these things in isolation. Our pain, we are far too complex to be able to separate them out into separate areas. So all of these things need to be done as part of a package of care. So again, I won't focus on all of these areas, but I'll focus on some of the areas that I think are really important to consider. And there are more information about other areas in the resources I've included later on. So our friends, our family and our work colleagues are really important people to have on board. So making sure that we have very supportive people around us who understand what we've experienced and who want to be able to help and support us to do what we need to do to be able to support ourselves and to manage our pain and our other conditions. Hobbies and interests are things that often get pushed to the side when we're going through treatment or when you're living with a long-term condition, but actually they're so important. So all of those things that you love and you have a passion for, that make you feel good about yourself, are really important to do. So by doing that, you allow all of those wonderful positive chemicals in your brain and your body that can actually turn the volume down on pain. They're free, they're accessible 24 hours a day, and they don't have any of the side effects that our medications have. So if I could prescribe anything, it would definitely be bucket loads of things that you enjoy. Some people it's crochet, for others it's gardening, for me it's playing board games and watching films with my family. Healthcare professionals, so I'm a bit biased being one, but actually we're here to support, whether it's pain specialist teams, whether it's your oncologists, whether it's late effect services that Dr. Lisa Durrant will talk about later. Your GP is such an important person to have on board, and to make sure that they have they know what's going on for you so that they can support you properly. So having that good lines of communication with them. And then there's a wider social care services that are available in charities as well. And PRDA UK and other charities are very good resources if you're not really sure where to start. From the psychological point of view, education is really important. So the more educated we are about our pain, what it means to us, whether it's dangerous or not. So if it's our normal pain, if it's a flare or a setback with our normal pain because of other stresses or illnesses that are going on at the time, or whether it's a new pain that actually you need to have investigated. And I think that's really important, having had a cancer diagnosis previously, that you have that insight and knowledge about yourself and your body, that you know what's your normal and what's not. And that you have that good relationship with those healthcare professionals, that you feel able to have that conversation with them and raise those issues if they appear. Planning, pacing and prioritizing, the 3 Ps that we love in pain management. So, and especially with pelvic radiation disease, prioritizing what activities you feel are really beneficial for you and things that you need to do over the ones that you'd like to do, but actually they can wait, or the ones that you don't actually want to do at all. You only have so much energy, especially if you're quite new out of treatment, you'll probably still be feeling quite fatigued. And so it's really important that you prioritize those activities so you can use your energy wisely. Once you've prioritized, you can then plan. So planning allows us to take some control back over our lives and reduce some of the anxiety associated with going out and doing activities. Once you've done those 2 things, then pacing is really, really beneficial. So pacing is about looking at that activity that you've prioritized as being essential for you to do and that you've planned about how you're going to do it, and then breaking that activity down into smaller, more manageable chunks, maybe taking rests in between. So if it's about going for a walk or going on a car journey, knowing where the toilet stops are along the way, knowing how long you can comfortably sit for before you need to get out and stretch your legs, those kinds of things that can make that experience a much more positive experience. So from the physical side of things, the physical aspects of managing pain are actually probably a much smaller part than the rest of them. But again, they're to be used as a collective wider package of care. Things like heat and cold can be really beneficial. So heat's very good for muscular pains. Cold can be wonderful for the burning, stinging sensations from neuropathy. Remaining active, doing exercise. So these don't have to be, prescriptive exercises where you have to do so many reps or sets. This can be any activity. So whether it's gardening, whether it's taking your dog for a walk, whether it's dancing around the kitchen with your kids, anything that gets you moving is really important. So we say motion is lotion. Your body needs to move to stay healthy. So it's really important that you find whatever it is that you can do, and that most importantly you enjoy. Again, thinking about releasing those wonderful pain relieving chemicals by doing things that you enjoy. Sleep hygiene, really important. I've spoken about sleep previously, and there is a resource that I've included which talks more about sleep as well. So having a really good sleep routine to set yourself up for the best night's sleep possible. And then the medications. So medications, again, are a small part, but they can be really beneficial for some people when they're used as that part of that wider supported self-management package. So I'm not going to go through all of the medications. However, this is intended to be a bit of an overview of the medications that are available, and you can use this to have a conversation with your healthcare team. This isn't to replace that, though. Obviously, they know you very well, and they know your allergies and your past medical history. So antineuropathics are often the mainstay for pelvic radiation disease pain. Due to the changes to the nerves, these medications can help to reduce the volume on the pain, but also they can help with some of the bowel and bladder symptoms, and sometimes anxiety and mood as well. However, they do have side effects, and so it's always worth having that conversation with your GP about the risks versus the benefits. So for instance, if you have very young children, or if you need to get up early for work, things like amitriptyline, gabapentin, pregabalin may not be as beneficial for you due to the side effects of feeling a bit sleepy the next day. However, if you really struggle to get to sleep, then amitriptyline can be a really positive one. So it's about having that conversation and knowing what your needs are. Opioids are very good for acute pain. Things like after you've had surgery, if you've had a broken bone. However, more longer term, there's not as good evidence for it. And actually the risks increase massively the longer that you're on them for. So it's really about having that conversation and weighing up those risks versus benefits. So the aim of any of these medications is to be on the lowest dose possible for the greatest benefit. And if they're not significantly improving your pain and helping you to do more, they're not doing their job. And that goes for this as well as the other supported self-management strategies mentioned on the previous slide. So for some people, topical pain relief may be beneficial if they've got very specific small areas of increased pain, sensitivity, burning, but not for kind of wider, more generalized areas of pain. And then you've got the more specialist interventions. So some specialist pain services may have these things available to offer. Again, they should be part of a wider package of care, including physiotherapy, occupational therapy, psychological therapies, for example, to give you that kind of supported self-care package. So the aim of this supported self-management of pain is to try and break that vicious circle of pain and to try and encourage a positive cycle of self-care and self-compassion, where not only the pain is improved, but your quality of life and well-being is also improved, so that you're able to do more and live more. Pete Moore, the author of the Pain Toolkit, which is one of my resources listed, talks about self-management, putting you back in the driving seat and getting pain out. I like to think that this is about putting pain in the boot, where you may be aware of it still banging away in the background, but actually it's up to you when you pull over and deal with it or not. So yeah, I think that would be my main aim and hope for supporting individuals to self-manage their pain, is that they can do more and live better. These are some of the resources that I've included. The ones highlighted in blue are very much focused around supported self-management, and definitely worth looking at. Many of my patients, and myself included, have had such benefit from reading them. Please do give them a look. So thank you very much for listening to my talk today, and if I've got time for some questions, then I'm more than happy to answer any. Thank you.
Thank you, Ria. Fascinating. Really learned so much myself, even though I'm not a clinician. We've had a great response in the chat box, so I have a couple of questions for you. Hopefully you'll be able to answer them for us. So we have a question. Oops, 2 seconds. My screen's just slid down. I can't see the question. Bear with me one moment. Okay, yeah. Probably more of a comment really than a question, but this one is really nice, saying, Unzia said, guilt is a big one for me, so I'm really glad to hear that you've acknowledged that in your talk. And then a question, we don't have a name, but there is a gender inequality when it comes to managing pain by healthcare clinicians. What's your view on that, Ria?
I'd like to think that that's improving as years go on and we do kind of more research and we learn more. However, I think you're right. There are definitely some gender inequalities. I think there are some preconceived ideas and some misconceptions sometimes about different sexes and how we experience pain. And that can work both ways. I think sometimes we think, a lot of health professionals think women are much better at managing pain because they have babies and we have periods, and and men aren't so great at managing pain because of that. And then you have the other way of looking at it, where actually there are some perceptions that women with emotions and hormones don't manage pain as well. And so it really depends on who you speak to, but I think you're right, there are definitely some inequalities around, and I think we need to work harder to make sure that balances out. Everyone's pain is very, very different, as I said, and so it doesn't matter what gender you are, your pain is your pain. Some people manage it well, some people manage it not so well. It depends on that whole package of what's going on in your life and around you. So I think we can't really judge how people may or may not experience pain by their sex, but let's hope that that gets better over the years. Fingers crossed.
Fingers crossed, yes. Thank you. Fiona asks, pain in hips diagnosed as osteoarthritis, but could this be PRD?
So I'm not so sure that radiotherapy itself causes arthritis. It can certainly make arthritis if it's already pre-existing. It can certainly flare it up. Pelvic radiation can cause microfractures, stress fractures. It can cause weakness with the muscles and the tissues, which can cause pain. So if you've already got arthritis there in the background, and then you have pelvic radiotherapy, that could potentially then make what maybe wasn't painful before now painful. Arthritis is a bit of a tricky one. People can have a diagnosis of arthritis on X-ray and imaging and actually not have many symptoms, or vice versa. So yeah, I think pelvic radiation definitely has an impact on the hips, on the joints, on the pelvic tissues, the nerves as well. So pain is quite prevalent, I think, for many people who have pelvic radiation disease, and the management of it can be very, very similar as well.
That leads me on to a really good last question. Are GPs able to manage pain well enough, or do people need referral to specialist pain clinics, do you think?
I think both. I think GPs are fantastic, credit where credit's due. And as Rebecca said earlier, you know, they have to know so much about so much that it must be very, very difficult. I think they have very, very good knowledge about some of the basic ways of managing pain. And hopefully with sessions like this and more support for GPs and more training and education, things available, that they will have more knowledge to be able to do it as well. But I think there is definitely a role for specialist clinics. I don't think it's fair to have GPs having to take that on board. It's a very, very complex condition, and pain is very complex itself without you know, having all of the consequences and complexities of pelvic radiotherapy as well. So I think, you know, GPs are there as your primary care providers to start the ball rolling. And then if you're getting to the point where actually you've tried lots of different aspects to manage the pain and that you're really struggling, having a referral to a specialist pain clinic or a specialist late effects clinic means you get more of that kind of holistic care by possibly, especially for the pain services. So we have multi-professionals involved, which can give a much more kind of holistic care. So I think both, we definitely need both. There isn't a room for kind of one on its own, definitely not.
Thank you.